languages, Arabic,
disponible dans les
Chinese,
6
French,
langues
English, Spanish, and
officielles
Russian,
des
as well
Nations
as
Unies, anglais,
Portuguese and
français,
Hindi.
espagnol, russe,
Now, let
arabe
me
et chinois, ainsi
introduce the
qu'en
quite strong
portugais
panel today.
et
First
en
and foremost, we
hindi.
have Dr.
Nous
Tedros
accueillons
Adhanom
aujourd'hui
Ghebreyesus,
Dr.
WHO
Tedros
Director
Adhanom
General,
Ghebreyesus,
and
directeur
Dr. Meg
général de
Ryan,
l'OMS,
Executive Director
Dr.
for
Michael Ryan,
WHO's Health
directeur
Emergencies
exécutif chargé
Program.
du programme OMS de gestion en
On
situation
the
d'urgence
more COVID
sanitaire.
side, we have Dr. Maria
S'agissant
Van
de la
Kerkhove,
COVID
Technical
plus
Lead on
précisément,
COVID-19.
nous accueillons Madame
Dr. Bruce Aylward will join us
Maria Van
shortly. He's
Kerkhove,
Senior Advisor to the
responsable
Director
technique
General and the lead on
COVID-19.
the ACT Accelerator. We have Dr. Kate O'Brien, Director for Immunization, Vaccines, and Biologicals. On the health emergencies for Ukraine, we have Dr. Sosifol, Assistant Director General for the Emergencies Response, Dr. Adelheid Marshang, Senior Emergency Officer at the Emergencies Program, and Dr. Flavio Salio, he's the Network Lead for the Emergency Medical Teams, the EMT Network Lead at WHO. And last but not least, joining us remotely is Dr. Maria Angela Simao, Assistant Director General for Access to Medicines and Health Products. With this, again, welcome, and let me hand to the Director General for the opening remarks.
Thank you, Christian. Good morning, good afternoon, and good evening. After several weeks of declines, reported cases of COVID-19 are once again increasing globally, especially in parts of Asia. These increases are occurring despite reductions in testing in some countries, which means the cases we're seeing are just the tip of the iceberg. And we know that when cases increase, so do deaths. Continued local outbreaks and surges are to be expected, particularly in areas where measures to prevent transmission have been lifted. However, there are unacceptably high levels of mortality in many countries, especially where vaccination levels are low among susceptible populations. Each country is facing a different situation with different challenges, but the pandemic is not over. I repeat, the pandemic is not over. We call on all countries to remain vigilant, continue to vaccinate, test, sequence, provide early care for patients, and apply common sense public health measures to protect health workers and the public. We continue to call on everyone to be vaccinated where vaccines are available. And we continue to work night and day to expand access to vaccines everywhere. Now to Ukraine. WHO's priority remains to support health workers and the health system to continue to provide care to meet immediate health needs. We have now established supply lines to many cities of Ukraine, but challenges with access remain. So far, we have sent about 100 metric tons of supplies, including oxygen, insulin, surgical supplies, anesthetics, and blood transfusion kits. Other equipment, including oxygen generators, electrical generators, defibrillators, and more have also been delivered. And we're preparing to send a further 108 metric tons. We are coordinating the deployment of 20 emergency medical teams of experts from many countries, pending a formal request for assistance from Ukraine's Ministry of Health. And we have opened a field office in Poland to support our operations in Ukraine and to coordinate the response to the health needs of refugees. But we're facing financial constraints in our ability to deliver the support needed. So far, WHO has received just $8 million of our appeal for $57.5 million. Huge amounts of money are being spent on weapons. We ask donors to invest in ensuring that civilians in Ukraine and refugees receive the care they need. And we continue to call for attacks on healthcare to stop. More than 300 health facilities are along conflict lines or in areas that Russia now controls, and a further 600 facilities are within 10 kilometers of the conflict line. Since the beginning of the war in Ukraine, WHO has verified 43 attacks on healthcare. WHO condemns all attacks on healthcare wherever they occur. Tragically, Ukraine is not the only place where patients, health workers, facilities, infrastructure, and supply are under attack. 2022 is only 75 days old, but already WHO has verified 89 attacks on healthcare around the world. In Afghanistan, Burkina Faso, the Democratic Republic of the Congo, Libya, Nigeria, the occupied Palestinian territory, Sudan, the Syrian Arab Republic, and of course, Ukraine. Altogether, these attacks have injured 53 people and killed 35, including health workers. That includes 8 polio health workers who were killed in Afghanistan last month. Attacks on healthcare not only endanger lives, they deprive people of urgently needed care and break already strained health systems. Although Ukraine is the focus of the world's attention, it's far from the only crisis to which WHO is responding. In Yemen, roughly 2/3 of the population, more than 20 million people are estimated to be in need of health assistance. In Afghanistan, more than half the population is in need, with widespread malnutrition and a surge in measles, among many other challenges. And in Ethiopia, 6 million people in Tigray have been under blockade by Ethiopian and Eritrean forces for almost 500 days, sealed off from the outside world. There is almost no fuel, no cash, and no communications. No food aid has been delivered since the middle of December. 83% of the population is food insecure. Our partners are running out of what little food they have and the fuel to transport it. About 3/4 of health facilities assessed by WHO have been damaged or destroyed. In February, WHO airlifted more than 33 metric tons of medicines and other supplies to Tigray, enough for 300,000 people. The first time we have been able to deliver supplies since July last year. In the past 2 weeks, WHO and our partners have distributed supplies to 65 health facilities in Tigray. But much more is needed, and we are now preparing to send an additional 95 metric tons of supplies, but no permission has been given yet. We estimate that 2,200 metric tons of emergency health supplies are needed to respond to urgent health needs in Tigray. Only 117 metric tons have been delivered, less than 1% of what is needed. But with no fuel, even if we can get supplies in, getting them to where they need to go is very difficult or impossible. The humanitarian situation in the neighboring Afar region also continues to deteriorate, with tens of thousands of people displaced and in need of food, shelter, and health services. But while the neighboring regions of Afar and Amhara are also affected, we have had far better access to those two regions than we have in Tigray. What is the impact of all this? People are dying. There is no treatment for 46,000 people who need treatment for HIV. And the program has been abandoned. People with tuberculosis, hypertension, diabetes, and cancer are also not being treated and may have died. As a result of the lack of fuel, some of our partners are having to scale back their operations. The situation in Tigray is catastrophic. The blockade on communications including on journalists being able to report from Tigray, means it remains a forgotten crisis, out of sight and out of mind. Yes, I'm from Tigray, and this crisis affects me, my family, and my friends very personally. But as the Director General of WHO, I have a duty to protect and promote health wherever it's under threat. And there is nowhere on earth where the health of millions of people is more under threat than in Tigray. Just as we continue to call on Russia to make peace in Ukraine, so we continue to call on Ethiopia and Eritrea to end the blockade, the siege, and allow safe access for humanitarian supplies and workers to save lives. Peace is the only solution in Ukraine, Yemen, Afghanistan, and Ethiopia. Christian, back to you.
Thank you very much, Dr. Tedros. Let me now open the floor to questions from the media. To get into the queue to ask questions, you need to raise your hand using the raise your hand icon on your screen, and do not forget to unmute yourself when called upon. And we'll start with Corinne Gretler from Bloomberg. Corinne, please unmute yourself.
Hi, thank you. I have a question for Kate. I wanted to ask about Medicago's COVID vaccine, Covifense. I see that its EOI has not been accepted. Would you be able to help me understand what that means exactly? Does that mean that Covifense will not be considered for EOL evaluation at all? And then also, why? Is that perhaps because of the tobacco link with Philip Morris? Just because I know that there are some strict rules around tobacco cooperation with the FCTC. Or if there is another reason, and I just want to understand what that means basically, and whether Medicago can appeal that decision at all. And sorry, just a super quick add-on. Has the war in Ukraine affected the WHO's approval process of the Sputnik vaccine in any way? Thank you so much.
Thank you very much, Corinne. I think we'll first go to Dr. Mariangela Simao, Assistant Director General for Access to Medicines and Health Products. Mariangela, please go ahead.
Thank you, Corinne, for the two questions, actually. First, on the Medicago, you know that the Medicago has applied for an emergency use listing by WHO, but due to its connections, it's owned by tobacco, by Philip Morris International, partially owned by Philip Morris International. So the process is put on hold because it's well known that WHO and UN has a very strict policy regarding the engagement with tobacco and arms industry. So the process is put on hold. It's very likely that it won't be accepted for the emergency use listing by WHO. On the Sputnik, yes, we were supposed to go to do inspections in Russia starting on the 7th of March, and these inspections were postponed for a later date. So the assessment has been the assessment in local, the inspections have been affected because of the situation, the uneven situation regarding flights options, and also the financial issues related to support with credit cards and some more operational issues. And this is being discussed with the Russian applicant, and new dates will be set as soon as possible. Thank you.
Thank you very much, Mariangela. The next question goes to Isabel Sacco from EFE. Isabel, please unmute yourself. Isabel, do you hear us? Please unmute yourself.
Hear me now? Hello?
Yes, now you're good. Yes, you're good. Please go ahead.
Hello? Do you hear me?
Yes, we do.
Hello, sorry.
Okay, it seems like Isabel doesn't hear us. We'll give it a second to see if we can fix the connection. If not, then we'll first go to Ashwin from the Observer Times in India, and we'll come to Isabel in a moment when you have fixed that. So Ashwin, Observer Times India, please unmute yourself.
Thank you for considering my question. My question is cDNA microarray technology useful to get ideal vaccine characteristic for COVID-19 disease? Thank you.
Ashwin, can you please repeat? We're not sure we got the full question.
Is cDNA microarray technology useful to get ideal vaccine characteristic for COVID-19 disease? Thank you.
Thank you very much. I'll go to Dr. Kate O'Brien for a start, please.
So the question of the composition of vaccines and the technology to be able to determine that composition is still, really an open matter for research and evaluation of vaccines. As you know, we have a number of different platforms of vaccines. Some of them are based on the virus itself. Some of them are based on either RNA or DNA sequences of components of the virus. So there's no one technology that is sort of the ideal technology or the critical way forward. I think the important part of this is an area of science that has been evolving very, very quickly over the past year, and importantly contributing not only to the development of very effective COVID vaccines, but also deploying that technology towards other vaccines. So cDNA microarray technology is not something specific that we're focused on as that particular technology. I really want to emphasize the range of options on vaccines, which have all been those ones that have achieved WHO, EUL, have all delivered on the protection against especially the severe end of the disease spectrum. Thank you.
Thank you very much, Dr. O'Brien. We'll try for a moment to come back to Isabel Sacco from EFE. Isabel, let's try again. Isabel, if you hear us, please unmute yourself. Yes, please go ahead.
Sorry, yes.
Minas Mishra from Reuters. Minas, please unmute yourself.
Thank you for taking my question. I'm just wondering what is causing the rise in infections again? Are we about to face a new wave?
What is causing the rise in? We got it. Okay, thank you very much. And Dr. Maria van Kerkhoff, please.
So thanks for the question. It's a combination of factors for which we're seeing an increase in case detections again around the world. In the last week, we saw an 8% increase in cases detected, with more than 11 million cases reported to WHO. And this is despite a significant reduction in testing that's occurring worldwide. So it's a combination of factors that is resulting in this increase. First is we still have Omicron, which is transmitting at a very intense level around the world. We have sublineages of Omicron, BA.1 and BA.2. BA.2 is more transmissible than BA.1 even. And this is the most transmissible variant we have seen of the SARS-CoV-2 virus to date. In the context of lifting of public health and social measures, lifting of the use of masks, lifting of physical distancing, lifting of restrictions of limiting people's movement, this will provide the virus an opportunity to spread. We have also incomplete vaccination coverage in many parts of the world, and in particular among people who are at risk of developing severe disease. And we have huge amounts of misinformation that's out there. The misinformation that Omicron is mild, misinformation that the pandemic is over, misinformation that this is the last variant that we will have to deal with. This is really causing a lot of confusion that's out there. So we are seeing increases in case detection around the world for a number of reasons. These are the same factors that have been driving transmission of this virus since the beginning of the pandemic. We completely understand that the world needs to move on from COVID-19, wants to move on from COVID-19, but this virus spreads very efficiently between people. And if we don't have the right interventions in place, the virus will take opportunities to continue to spread. And the more the virus spreads, the more opportunities it has to change. So it's a number of factors. The good news is that we have the tools that can reduce the spread. We know that masking works. We know that physical distancing works. We know that vaccination saves lives. And so we need to continue, as the DG said in his speech just now, and as the Director General has been saying since the beginning of this pandemic, it's about a layered approach and using these tools most effectively and making sure that we not only save lives with vaccination, earlier clinical care, good testing, but we also take measures to reduce the risk. So we are concerned that we're starting to see an increase in case detection again. And again, it's within our control. We do have some power over being able to limit the spread, and we really need to remain vigilant and do what we can, where we can, to reduce the spread.
Just maybe add to that point, because I think when we look at these data and deep into them, and we look at the hospitalizations and deaths, again, the overwhelming majority of people who are getting very sick and dying are vulnerable individuals, older individuals, people with underlying conditions who have not been vaccinated or have not received a full course of effective vaccines. And we again need to restate the importance in every country. This is not just a North-South issue. In every single country needs to look again at vaccination levels in its most vulnerable, whether it's using booster policies or not, and ensure at the very minimum that every individual who is vulnerable has 2 doses of effective vaccine, and in situations where boosters are available, that and policy is in place as well. Because I think we'll see this virus is still, as Maria said, very fit. It's still moving around quite easily. And in the context of waning immunity and the fact that vaccines don't work perfectly against infection, the likelihood is that this virus will echo around the world. It'll be high in some parts at some times. It'll move and be higher again. It'll move to another area where immunity is waning. And the virus will pick up pockets of susceptibility and will survive in those pockets for months and months until another pocket of susceptibility opens up. This is how viruses work. They establish themselves within a community and they'll move quickly to the next community if it's unprotected. But what can happen is if communities around a virus are well protected, the virus can sustain itself even in small communities. It can stay there, it can rest there and then wait until susceptibility grows in other communities. We've seen this, I'm looking at Bruce, in polio and other places. So I do think it's very important that we recognize that the transmission of this disease will occur. It will wax and it will wane. It has not settled down into a purely seasonal or predictable pattern yet. So the idea that we're through it in the Northern Hemisphere now and we've got to wait till next winter, I think when we look at increasing rates, for example, of cases and deaths in the likes of the UK, I think we need to be very, very, very vigilant. We need to be very cautious. We need to watch this very carefully. And we need to focus on getting the most vulnerable appropriately vaccinated. And we need to do that as quickly as possible in every country.
Thank you very much, Dr. Ryan. Next question goes to Lizzie Davis from The Guardian. Lizzie, please unmute yourself.
Hi, thanks for taking my question. I'd like to know if you could give any more detail about the 43 attacks on healthcare in Ukraine. Specifically, what kind of establishments you're talking about when you talk about healthcare? Where have most of the attacks taken place? Are you able to give any geographic information? And do you also have any information on how many healthcare workers in Ukraine have been injured or even killed in the same time period? Thank you.
Thank you very much. And we'll start with Dr. Sosifal, Assistant Director General for the Emergency Program, in response.
Merci, Christian. Je pense que les attaques au niveau des structures de santé se multiplient de jour en jour. Donc, nous sommes à 43 aujourd'hui, mais il est probable même qu'à la fin de la journée ou demain, on aura encore un nombre plus important. Et la distribution géographique est diverse. Il peut s'agir des zones qui sont déjà sous contrôle des forces russes, mais aussi dans des zones intermédiaires qui ne sont pas sous le contrôle. Et notre approche n'est pas de donner de détails sur la localisation géographique. Notre objectif est de protéger les structures de santé, les populations qui ont besoin de ces structures de santé, mais aussi des travailleurs de santé donc, qui doivent être protégés. Et c'est ainsi que nous rapportons donc, de façon très indépendante, sans pouvoir dire précisément donc, qui est à l'origine des attaques. Je pense qu'il est important que toutes les forces impliquées donc, tiennent compte de la nécessité d'avoir des structures de santé fonctionnelles même pendant le conflit pour pouvoir protéger ces populations qui sont déjà vulnérables. Nous savons qu'il y a beaucoup de personnes âgées qui ne peuvent pas se déplacer. Nous savons qu'il y a des enfants malades dans les hôpitaux qui ne peuvent pas se déplacer. Donc, toute notre communication est pour protéger donc, ces personnes vulnérables. Donc, ça va continuer, nous allons continuer à les monitorer, mais toutes les parties doivent tenir compte de la nécessité donc, de respecter ce droit humanitaire international qui est de protéger les structures de santé. Merci.
Thank you, Sose. I think it's important to reflect here that this is, and the DG referred to this, we're only very short part into this year, and we have never seen, globally, never seen this rate of attacks on healthcare. Health is becoming a target in these situations. It's becoming part of the strategy and tactics of war. It is entirely unacceptable. It is against international humanitarian law. And in fact, under international humanitarian law, conflicting parties are actually instructed to specifically take measures to avoid attacking or inadvertently destroying or hurting health workers or health facilities. They don't bear a responsibility not just to not attack. They actually bear a responsibility to ensure that they don't attack, to identify those facilities, to deconflict those facilities, and to ensure that they do not, as part of their prosecution of war, attack those facilities. So it is not only against international humanitarian law to carry out attacks like this, it is actually in the responsibility of all parties, and I might say all parties in conflict, to do so. We are, as the DG again has said, working very hard with many partners to get emergency medical teams on the ground. But how can we put emergency medical teams on the ground if the very facilities that they may want to go and support are going to be attacked and going to be bombed and going to suffer catastrophic damage? This crisis is reaching a point where the health system in Ukraine is teetering on the brink. It is doing exceptionally well. It needs to be supported. It needs to be shored up. It needs to be given the basic tools to save lives. Part of that is deploying teams in to support that. But how can you do that in all conscience if the very infrastructure that those people will go into support is being under direct attack? And I don't know if Flavio Salio is back from leading our EMT initiatives in Ukraine, and maybe Flavio would like to comment on this. But this issue is more important than bricks and mortar. This isn't just about the destruction of buildings. This is about the destruction of hope. This is about taking away the very thing that gives people the reason to live. The fact that their families can be taken care of, that they can be cured if they're sick, that they can be treated if they're injured. This is the most basic of human rights, and it has been directly denied to people. And we are then in a position where we can't send assistance to those people because the very act of attacking those facilities or not taking care to avoid those facilities means we can't send the appropriate help when it's needed. Flavio.
Thanks, Dr. Wright. Yes, it's becoming for sure a challenge to ensure that the right level of support reach facilities. We have been in touch with the hospital requesting support, in particular specialized care, where basically external medical team can bring the added value and support the local health system. The challenges remain obviously safety of the staff, safety as well of the patients themselves. They become today the challenging point at this stage. There is as well a significant component that include evacuation of patients from the areas in which are targeted patient that obviously suffer from chronic condition and does require as well support. So there is a ongoing evaluation of the system that can facilitate medical evacuation towards the borders. Then obviously across facilities in Europe that will accommodate them themselves. As a last point, I think the augmenting the capacity through temporary facility could be the options, but challenged by the element that Dr. Ryan described in terms of the conflictions as well, and ensuring that if we bring such kind of capacity, is recognized by obviously the parties to the conflict. Thanks.
Thank you very much all for these explanations. Next question goes to Sarah Nui from The Telegraph. Sarah, please unmute yourself.
Hi there. Two quick questions, if that's okay. Firstly, you've talked a lot about the risk of COVID spreading in Ukraine and other infectious diseases. Obviously, as Mike just said, the health system is struggling, but do you have any evidence of increasing COVID cases or measles or TB as people flee? And secondly, probably for Maria, could you just tell us a bit more about the global spread of BA.2, and is there any evidence that it's more severe or more likely to evade vaccines? Thank you.
Let's start with the emergencies question on Ukraine, on the diseases and the situation there. Dr. Marchand, please.
Yes, thank you. We have stated previously that the COVID-19 surveillance system in Ukraine is holding, is strong, is detecting cases. We see at the same time that the testing the testing has decreased. Still, we have captured now, I think, something like more than 30,000 new cases, and we're trying to place that. If anything, it indicates an increase. This is something that we have suspected, but we also need to say that there is a decreasing in access and capacity to deal with these cases. We do understand that between the 23rd February to the 8th of March, there was a 22% decrease in the number of beds available with oxygen, for example, and a 20% decrease in the number of intensive beds when they are most needed for some of those health risks that we have pointed out previously, and that is trauma and injuries, and an increase in acute conditions due to non-communicable diseases that we have already pointed out.
Thank you very much, Marchand, and Dr. Saucier-Ford, please.
Merci, Christian. Juste pour ajouter un point sur le risque d'augmentation des maladies transmissibles, je pense que c'est un risque réel. Si on voit avec COVID-19 déjà, du fait du mouvement des populations, du niveau de vaccination qui était déjà faible, à moins de 34% de personnes qui ont reçu des doses, et les conditions dans lesquelles les gens sont rassemblés, il y a un risque d'augmentation des cas de COVID, et aussi le niveau de testing est très bas en ce moment. Je pense que nous devons faire face à ça, et nous l'avions dit la fois passée, quand on combine cela en problème d'approvisionnement en oxygène pour les cas graves, la situation peut être catastrophique. Si on regarde d'autres maladies aussi, à risque pour les enfants, donc les enfants qui ne peuvent pas être vaccinés en ce moment contre la rougeole, la rubéole, on risque de voir aussi des flambées épidémiques. Le problème d'accès à l'eau potable quand les gens se déplacent peuvent entraîner des maladies diarrhée, dysenterie et autres. Mais pour d'autres maladies, donc, où il y a déjà un nombre important de patients sous traitement, tels que la tuberculose, le VIH, le fait d'avoir des interruptions de traitement aussi va aggraver les problèmes de résistance aux médicaments pour la tuberculose, mais aussi le risque de transmission à d'autres personnes dans ces conditions où les populations sont dans une certaine promiscuité.
Thank you much, Dr. Fall, and we turn to the COVID part of the question for Dr. van Kerkhoff.
Thanks, Sarah, for the question about BA.2. So in the last 30 days of the more than 400,000 sequences that have been with sample dates in the last 30 days, 99.9% of those have been Omicron. And among those, about 75% of those are BA.2 compared to BA.1, about 25% are BA.2. BA.1. Let me say that again. Of the sequences that are available, about 75% are BA.2 and 25% of those are BA.1. All of these are Omicron and all of these are variants of concern. So we are seeing an increase in the proportion of BA.2 that is detected. However, the amount of testing that is happening worldwide, as we have mentioned previously, is dropping substantially. So our ability to track this virus, our ability to track BA.2 is compromised because testing is reduced. And you can't sequence those who you don't test. So we need a very strong surveillance system around the world for COVID-19. Despite all of the challenges that we are facing, we still need to maintain testing. We still need to maintain robust sequencing and making sure that we have good geographic representation of the sequences that are shared so that we can really track this virus in real time. We as WHO are working with literally thousands of public health professionals and scientists around the world to be able to track virus evolution and look at what these changes mean in terms of our ability to control the spread or reduce the spread, our ability to use tools effectively, and of course, to look at the use of vaccines. We should say that vaccines, COVID-19 vaccines, remain incredibly effective at preventing severe disease and death, including against Omicron. You asked a question specifically about severity. We do know that Omicron is less severe compared to Delta. We do not see changes in severity of BA.2 compared to BA.1 at population levels. However, with huge numbers of cases, you will see an increase in hospitalizations. And we've seen this in country after country. The sheer volume of cases that we have seen has really translated into increased hospitalizations. And that in turn has translated into increased deaths. What we can say when we look at deaths in countries around the world, as Mike pointed out earlier, as the DG has pointed out, the deaths are primarily occurring in people who are not vaccinated or people who've only had one dose of vaccine. So it is absolutely critical that that people receive vaccines around the world, in all countries, and in particular, people who are at risk of developing severe disease. If you look at some countries right now that are experiencing high amounts of mortality compared to previous waves, look at the proportion of those populations that have actually received the vaccines, and look in particular how many above the age of 60, those who have underlying conditions who have received vaccines. And in fact, in a lot of those countries, that proportion is quite low. So it is really critical not just to vaccinate, but to ensure that those who are at most risk receive the vaccines first, because the vaccines are saving lives. We cannot stress this enough. So it is really important that we keep up the systems that have been put in place for COVID, for strong surveillance, strong testing, getting patients into the clinical care pathway early, increased vaccination. It's this layered approach that is really going to help us get a handle on COVID-19. And we have the power right now to take the death and devastation out of COVID. But we have to make sure that vaccines are received by all people, and particularly those who are most at risk in all countries.
Thank you very much, Dr. van Kerkhoff. And we managed to reach Isabel Sacco from EFE in writing. So as we're already talking about BA.1 and BA.2, let me read out the question she has on that. What do you know about the new supposed variant combining BA.1 and BA.2? Where has it been identified, and is it a source of?
So I'll take a stab at that question. I'm not aware of a combination of BA.1 and BA.2. You may be referring to the recombinant that we mentioned last week, which was a combination of AY.4, which is Delta, and BA.1, which is Omicron. And that has been detected in 3 countries, and it's very low level of circulation, as we are aware, but not aware of a combination of BA.1 and BA.2. These are sublineages of Omicron. Again, BA.1 and BA.2 are Omicron, and they are already classified as variants of concern.
Thank you very much.
Can I just add, just so that's not misunderstood as well, those sublineages can co-circulate. So you could, it's not that there's a combined virus. What you have is multiple versions of the virus circulating at the same time. And depending on the situation, one can gain the upper hand over the other. And it depends sometimes on just when it arrived So, for example, the predominance of BA2 in many Asian countries, maybe that BA2 emerged slightly later and has driven the ongoing surge in Asia. But there's still BA1, there's still other variants and lineages causing disease. So it's not a combination of both as in one virus, but a combined effect of both when they're both transmitting.
Thank you very much. Both very important explanations. Next question goes to Bianca Rotier from Globo, Brazil. And Bianca, please unmute yourself.
Hi, Christian. Thanks a lot for taking my question. And in fact, it's a follow-up with Isabel Sacco question, because Brazil said that the country has now 2 cases of this Delta Chrome. They are calling it Delta Chrome. So I'm not sure if I understood the answer, because there they are saying that it's AY.4 BA.1. So yeah, if you can explain better, and yeah, if you have information about this, thanks a lot.
All right, let's go into the explanation, Dr. van Kerkhoff.
Yes, thank you. So this recombinant is a combination of AY.4, which is Delta, just sublineage of Delta, and BA.1, which is sublineage of Omicron. And this recombinant has been detected in a number of countries. I mentioned 3 countries, and you've just mentioned Brazil. Now, as we look more, as we do more sequencing, it is possible that this recombinant virus will be detected in other countries. But it is circulating, as we understand, at very low levels.